Good morning. My name is Lauren Lele, and I am the Director of Community Benefits and the Community Collaborative at Newton-Wellesley Hospital. Thank you for joining us and welcome to our program titled, Can We Talk? Speaking with your loved ones and physician about serious illness. Today's program's featured speaker is Dr. Julia Raglin and is being hosted by the Newton-Wellesley Hospital Palliative Care Council. Palliative Care is one of the 8 councils within the collaborative that hold educational sessions open to the whole community. Before the program officially starts, I would like to mention a few logistics for the next hour. We will be leaving plenty of time for questions and answers, and we would ask that you use the Q&A feature at the bottom of the screen to type your questions in. I'll monitor these questions and being asked, I will ask Dr. Raglin these at the end of the speaking portion of the program. And now let me tell you a little bit about Dr. Raglin. Dr. Julia Raglin serves as the Director of Palliative Care Education at Newton-Wellesley Hospital. She began her career as a primary care physician before transitioning to hospital medicine. She joined the hospitalist service at Newton-Wellesley Hospital in 2002 and served as chief before stepping down to become the founding director of the Newton-Wellesley Hospital Palliative Care Service. Dr. Raglin is board certified in internal medicine and hospice and palliative medicine. She is an associate clinical professor at medicine at Tufts University School of Medicine, and her academic interests are focused on teaching communication skills as she leads the Newton-Wellesley Hospital Serious Illness Conversation Training Program. She was named a Howland Master Clinician at Newton-Wellesley Hospital in 2014, which provides an annual endowment to support her work in palliative care education. Dr. Raglin lives in Needham with her husband and 3 grown daughters. And now to begin this morning, I will turn it over to Dr. Raglin.
There we go. Okay. Well, good morning, everyone. I'm delighted to be here and excited to have this opportunity to speak with you about what you and your loved ones can do to help ensure that you receive health care that aligns with your values and priorities in the face of serious illness. Hopefully, some of the things we will talk about will also give you some ideas on how to advocate for excellent communication with your healthcare providers, even before you or someone you love develops a serious illness. As a physician who's worked in the hospital setting for over 20 years, I see firsthand what a difference effective and ineffective communication and planning can have on the patient and family experience. So conveniently, this week is National Healthcare Decisions Day, which aligns perfectly with our topic today. And the mission is to focus and empower the public to express their wishes regarding healthcare and for providers and facilities to respect those wishes. So a national survey done by the Conversation Project in 2018 found that 92% of Americans say it's important to discuss their wishes for healthcare if they were to become seriously ill, but only 32% have had such a conversation. 95% say they'd be willing to talk about their wishes, and 53% say they'd be relieved to have these discussions. So I'd like to tell you about Mrs. D. Mrs. D is, I think, an example where there were some better outcomes in a difficult situation when the family had communicated well with each other and with their providers. Mrs. D, also known as Teresa, was an 80-year-old woman who was widowed and had 3 children. She loved to travel and play tennis. She had developed dementia a number of years ago and was able to live independently until 2020. However, she then moved into a memory care unit at an assisted living facility. She had mild COVID in early 2021 and subsequently had a decline in her cognitive function and mobility and lost about 20 pounds over a 4-month period of time. She was admitted to Newton-Wellesley in December of 2021 with increased lethargy, lab abnormalities consistent with dehydration, and evidence of pneumonia. She was treated with IV fluids and antibiotics, and despite improvement, In the lab results, she continued to need oxygen and was refusing most oral intake. Due to her dementia, she was unable to make her own decisions. The team was concerned about Teresa's overall clinical picture, and a family meeting was set up. The family described their mother as fiercely independent and someone who liked to be in control. They understood that dementia is progressive and ultimately a terminal illness. The team said that it was possible their mother could improve, however, she was expected to face continued decline and be at high risk for recurrent hospitalizations. The team asked, what would Teresa say was most important at this point in her life? As it turns out, Teresa had had discussions with her children over the years prior to her dementia. She had told them that she knew family members with advanced dementia who couldn't recognize family and were dependent on others for all of their care needs. And she said, quote, I can't be that person, end quote, feeling it would be an unacceptable quality of life to be in that state and to be a burden on those who she loved. She made clear to her family that she would not want a feeding tube or be put on a ventilator to extend her life if she was in that condition. She always said she hoped to die in her sleep and to maintain her dignity. They also felt that their mother would not want to cycle in and out of the hospital at the end of her life. Given her clinical condition and what the family indicated were her values and goals, the medical team recommended that they transition to comfort-focused care as the best way to support the patient's wishes for control, dignity, and a peaceful death, and the family agreed. Mrs. D was discharged back to her assisted living facility with hospice in place. And although this situation was very emotional for the family, they had some peace knowing that they were honoring their mother's wishes. The family was unified and did not experience conflict because they were prepared for the day these decisions would be needed. They were also prepared in their understanding that dementia is a progressive and ultimately terminal illness, which unfortunately many of our patients and caregivers don't understand. So today, I'm going to cover three main areas. The first is speaking with loved ones about values and goals related to healthcare, which we call advanced care planning. The second is serious illness conversations, which is speaking with your physician about what matters most in serious illness. And the third is when expert help is needed, how to get palliative care involved. So really looking as we move from younger, healthier adulthood to older age and development of serious illness, regardless of age that serious illness develops. There are three key things that you can do to help you and your loved ones be better prepared for managing serious illness and health crises that may arise, as well as preparing for end of life that we all will inevitably face. And as you see on this, starting with in the healthier state, that everyone should be choosing a healthcare proxy. And then over time, as people, while they're healthy, but also as they may develop chronic illness, they should discuss values and goals with loved ones with the focus on distant future care. And this continues while we're aging and through chronic stable illness. Then as people are diagnosed with a more serious illness, then it becomes more important to engage in conversations with our clinicians together with our loved ones. And the focus shifts more to near-term or in-the-moment care decisions. And this happens when people have advancing chronic illness or acute life-threatening illness. So definition of advanced care planning that I like is advanced care planning is a process that supports adults at any age or stage in health in understanding and sharing their personal preferences, life goals, and preferences regarding future medical care. So key steps, there are two. The first is to choose a surrogate decision maker, also known as a healthcare proxy, sometimes also referred to as a healthcare agent. And people ask, well, why is this important? It turns out that a high percentage of people end up needing their healthcare proxy to make decisions on their behalf at the end of their lives. One study looking at nearly 4,000 people who had died over the age of 60 found that just under 30% who needed decision-making lacked the decision-making ability, so their proxy needed to make decisions on their behalf. And people also say, well, what happens if I don't have one? Well, if we don't have a healthcare proxy and major medical decisions need to be made, then we would look to the family. But if the family is in conflict and not in unison, then we would need to go to court to get a legal guardian. And there are other situations if patients need to go to a skilled nursing facility for rehab or long-term care. If they don't have a proxy, then again, we would need to go to court. And this can be quite cumbersome. And I think most people truly would prefer that a loved one or a trusted individual serve in the role of decision maker. Some other things to highlight is that this is appropriate for all adults over the age of 18 to have a healthcare proxy because something can happen suddenly and unpredictably. This is a sample of the Massachusetts healthcare proxy form, but you don't need a specific form, just needs to have key elements, including your name and information, the date that you've signed the document, the name of the person you would want to be your healthcare decision maker. You can also add a second name of someone to be the alternate proxy. You need 2 witnesses to attest to your sound mind, but they do not need to be an attorney, and an attorney does not need to be present. It simply cannot be the proxy or the alternate proxy, also can't be your physician or a member of the healthcare team. And the second key step in advanced care planning, which we'll go into in more detail, is having discussions with your loved ones that clarify your values over time. In effect, you're preparing those people in case a situation comes up where you're not able to make decisions for yourself. So the main objectives of advanced care planning are to prepare you and your loved ones to participate with clinicians in making the best possible in the moment decisions. In other words, we're not trying to make actual decisions about healthcare in advance of when situations arise. What we find is that is not very useful because we can't predict what's going to happen exactly in terms of our health, and we can't know exactly what decisions we'll be facing. So what the discussion should really focus on is what are desired or feared outcomes rather than specific medical procedures and interventions. Documentation about your values and priorities or feared or desired outcomes can be very helpful. However, there are limitations. What we find in practice is often people can't find those documents, or the documents don't exactly pertain to the situation at hand. It's important to know that they're not legally binding either. So while they will give guidance to your decision makers, they don't actually spell out exactly what clinicians and healthcare decision makers must do. So what does it mean? What should we talk about with our loved ones about values and goals? Well, some questions to think about are: what makes life worth living for you? This differs for all of us and is very personal. What would make life not worth living for you? Some people might say, if I can't recognize my family, if I'm not able to eat, if I'm not able to enjoy watching the Patriots, everybody has their own personal thing. What are your hopes and fears about the future as your health declines? Are there specific religious or spiritual factors that might impact your healthcare decisions? How has the healthcare experiences of others impacted your thoughts about the care you would want or not want? Really need to emphasize that this is a process and not a one-time event. Many people, opinions and views will change over time. So many people, particularly younger people who are very healthy, many people think they can't tolerate a severe disability. They think they might rather die if they couldn't use their arms and legs, let's say. However, studies show that that is not usually the case, and that many people learn to adapt to a new reality. On the other hand, it's also common for people to want more aggressive medical interventions and efforts to prolong life as they're healthy. However, as people age and develop serious illness, and as prognosis worsens and burdens of illness and treatments increase, people's goals and values shift, and often shift away from these more aggressive medical goals to focusing more on non-medical goals as their illness progresses. So Many people avoid difficult and uncomfortable conversations with their loved ones or even with their doctors about the possibility of serious illness or death. But it turns out you're not protecting your loved one by avoiding conversations. You may actually be making things harder for them if they end up having to make decisions on your behalf. One study in 2011 showed that at least a third of surrogate decision makers who had to make end-of-life decisions for a loved one experienced negative emotional burden as a result of that. And that included just feelings of stress, guilt, anxiety, complicated grief and bereavement, and post-traumatic stress disorder. And they also, studies have shown that knowing what the patient's preferences, values, and goals were reduced the negative impact on surrogates. And this is something that we routinely see in the hospital day in and day out, how it's much more difficult for loved ones to make end-of-life medical decisions when they've not had conversations in advance. And as in the case that I mentioned, Teresa or Mrs. D, how it really helped the family to have had conversations with their loved ones and providers. So to summarize, we sometimes talk about advanced care planning as a gift that you can give your loved ones. It reduces emotional burden on surrogate decision makers. It helps you maintain some sense of control over how things will go. And it also may reduce family conflict. So how do we do this? How do we do advanced care planning? Well, it turns out there are many useful resources available to you online. And those are listed here. They have different strengths and weaknesses. I'm going to go into the conversation project in a bit more detail, but I'll highlight that one of the simplest to use is 5 Wishes. It's written really in lay language and was one of the first nationally available advanced care planning tools. And it focuses on both personal, emotional, and spiritual wishes in addition to thoughts about medical treatment. I also thought it was worth mentioning the website Cake, which I recently looked at again, hadn't looked at it in a while. In addition to having useful information about advanced care planning, it also has helpful information about building legacy, about planning things like funeral, about having support resources for people who are dealing with grief and bereavement. They also explore mortality through the arts with poems and books and other links. So I found that to be an interesting website. But the one we're going to focus on a little bit more is called the Conversation Project. And this is a public engagement initiative from the Institute of Healthcare Improvement. And one of the co-founders, Ellen Goodman, she was motivated to start the Conversation Project after her own experience struggling with making decisions for her mother at the end of her life, and wished that she had had conversations with her mother to know more about what she would have wanted. A quote on the Conversation website that I liked, they talked about the goal of helping everyone talk about their wishes for care throughout life so that those wishes can be understood and respected. And they said, quote, "We believe that the place for this to begin is at the kitchen table, not in the intensive care unit, with the people who matter most to us before it's too late." And a common expression we use in the line of work that I do is it's often too early until it's too late. And many people avoid dealing with things thinking it's too early, and then they miss opportunities to make a real difference. I also think it's interesting, Ms. Goodman is an excellent speaker, and she talks about how childbirth, which is a major life event, was revolutionized by baby boomers in the past 40 to 50 years. And it used to be a very medical, technical, and impersonal event. What she has proposed is that baby boomers and those behind them should be fighting for the same kinds of changes for end-of-life care, which has become extremely medical and technology focused. These are intensely personal events, and how things play out for our loved ones really stays with us forever. These memories stay with us forever. And so if we can take some control and active engagement in making these more personal, we will all be better served. So the Conversation Project has a number of free guides online to help at various stages of conversations, preparing for conversations. And I will highlight 2 in a few minutes. So we've mentioned serious illness, and before I talk about this further, I'd like to define what I mean by that. A health condition that carries a high risk of mortality and either negatively impacts a person's daily function or quality of life, or excessively strains their caregivers. And here are some common examples. They include advanced cancer, liver cirrhosis, dementia in its more advanced stages, congestive heart failure, kidney failure, COPD, and there are others. And these are diseases that in general are not curable and will progress over time and tend to have a high burden for patients and their families. And so that's what we define as serious illness. So I'd like to tell you now about a seriously ill patient that I cared for a number of years ago. And this is an example where there were missed opportunities. And I'd like to highlight that and how we can do better. So Mr. A is a 75-year-old veteran who'd been admitted to the hospital 5 times before the hospitalization where I met him. And those hospitalizations were for symptoms and complications of congestive heart failure and emphysema. Despite treatment, he'd had progressive worsening of shortness of breath. He required home oxygen and many medications. Each hospitalization was more complicated, and he twice required care in the intensive care unit. During his final hospitalization, he was admitted to the ICU with shortness of breath due to his congestive heart failure, and he developed kidney failure. He was faced with the urgent decision to face the end of his life or start dialysis. Unfortunately, he and his family felt unprepared for this event. They didn't fully understand his prognosis prior to this point, nor had they ever discussed what would be most important to Mr. A if he ever faced these kinds of decisions. What would he be willing to go through in order to gain more time? What would be an acceptable or unacceptable quality of life? What gives his life meaning at this point? Given the urgency of the situation, they opted to start dialysis. He improved enough to transfer to the medical floor while continuing on dialysis, which is when I met him. At that time, he had many physical complaints, and he was expressing doubt about the decision to start dialysis. When I asked what the hospital experience was like, he said it was terrifying. When asked what bothered him most, he reported many troubling symptoms, and many of these were due to the care we were providing, including pain from a urinary catheter, pain from daily blood work, IVs, and cardiac monitoring. And that does not include the many symptoms he experienced from the primary illnesses that he experienced. After further discussion with him and his daughter, he expressed that he'd had a terrible quality of life over the past year, and his priority was to be with his family. Arrangements were made to transfer him out of state to be near his family. Shortly after the transfer, he decided to stop dialysis and to go on hospice, and he died a few weeks later with his family nearby. So I spoke with his daughter a couple of weeks after her dad had died, and she was incredibly grateful for the care Newton-Wellesley had provided her father. However, she felt, as did I, that we could do better in several areas. She and he, both the patient and family, were unaware that the prognosis was so poor, and she wished that they had gotten information earlier, that there were missed opportunities across those hospitalizations to prepare Mr. A and his family for what was to come. They felt unprepared for the decisions that were needed, and some of these could have been anticipated. And they regretted that there was not more time for closure or quality time together. Sadly, this case is not atypical. Studies have found that fewer than a third of people with end-stage diagnoses reported having any discussion with clinicians about prognosis and values and goals. And that when conversations happen, they are frequently late. One large study of patients with advanced cancer found that the first such discussion on average happened 33 days before death. And over 50% of those first conversations happened when people were in the hospital, and frequently with providers that were not their trusted providers. So the transition when this happens from life-prolonging and curative efforts can feel very abrupt. And there's certainly, our hope is that we can do better. This is a wonderful quote by Dr. Atul Gawande, author of Being Mortal, Medicine and What Matters in the End. People turn out to have priorities in their life besides just living longer. We need to ask people what their priorities are, especially when they have a serious illness or frailty. If we don't ask, our care and what we do to people isn't aligned with what matters most to them, and then you get suffering. So this is a cartoon that I use in virtually all of my talks on communication and serious illness. I'm right there in the room and no one even acknowledges me. And I think the elephant in the room is the possibility that serious illness is progressing and end of life may be nearing. It's not discussed by providers and by patients and families. And when we don't talk about it, then things always default to more medical interventions with the assumption that life prolongation is the only goal, when the reality is that for most people, as serious illness progresses and the burdens of the treatments and illness progress, and the likelihood that time is getting shorter, people most often have other things on their list of priorities, such as avoiding suffering, strengthening relationships with family and friends, being home and spending time with loved ones, being mentally aware, not being a burden on others, and achieving a sense that their life is complete. So serious illness care right now really looks like the blind leading the blind. As I've mentioned, patients and families often have a limited understanding of their illness and what to expect, and clinicians often have limited understanding of what the patient's values and goals are. The ideal is when somebody has a serious illness that they understand about their condition and prognosis and what the future may look like and what is medically possible, and that the physicians learn what matters most to the patient given their goals. And what this enables us as physicians and other clinicians to make treatment recommendations that are most appropriate and aligned with the patient's priorities. And we think of goals, we talk about goals a lot. Well, they're medical goals. Those could be cure, prolonging life, maintaining function, maximizing comfort, but they could also be non-medical goals, such as living long enough to reach a life event, such as a graduation or the birth of a grandchild. It could be creating legacy, mending relationships, addressing spiritual concerns and being at peace with God. We also know that if we don't talk about prognosis and what to expect in the future, that we know that patients will make different decisions when they know that time is limited. And so it's important to offer people that information. So in an effort to improve the care and the communication that is provided when people are living with a serious illness, a group called the Ariadne Labs started a program called the Serious Illness Conversation Program. And the mission of the program is to improve the lives of all people with serious illness by increasing meaningful conversations about personal values and priorities with their clinicians. And what they did was create a guide for having serious illness conversations that is standardized and trainable. And it turns out that having conversations about serious illness and about prognosis as time is becoming shorter is really a complex procedure. As you can imagine, emotions are very high. And most of us, sadly, were not trained on this in medical school, in nursing school, and in other disciplines. And so this is a tool that we use for training providers across Mass General Brigham. It's been a system-wide priority with over 2,000 people trained, using actors to play patients. We do role playing. And we've trained over 400 at Newton-Wellesley, and training is ongoing with a focus right now on some inpatient nurses. What they found in studies, the goal of the project was for conversations to happen with clinicians earlier and actually before the hospital stay. They've studied with oncologists at the Dana-Farber and with primary care physicians at the Brigham and Women's Hospital that when providers were trained and prompted to have conversations with people with serious illness, it resulted in more conversations, earlier conversations, better conversations, and more documentation. And what was also amazing is that they found that there was reduced rates of anxiety and depression in the patients who had these conversations. This is remarkable because it's the opposite of what the physicians and other providers think. We worry as providers that we're going to make our patients sad and anxious to talk about this. But it turns out that people are already feeling sad and anxious about their health and their declining health. And giving them the opportunity to talk about it actually alleviates some of that anxiety and depression. So some of the guiding principles behind the program and Serious Illness Guide is that serious illness conversations with clinicians help patients focus on how they want to live. It's not all about death and dying. It's how they can make the most of the time they have left. And that we know that people want the truth about what to expect in the future. They may want different amounts of information and delivered in different ways and at different times, but the majority of people do want information about what to expect. And as I mentioned, people have goals and priorities besides living longer, and learning about them as clinicians empowers us to provide better care. And simply giving our patients the opportunity to express fears and worries is therapeutic in and of itself, even when we can't fix the overall situation. Multiple studies have shown benefits of early values and goals conversations. And when we say early, we mean when death is not imminent and when you're not in a crisis needing immediate decisions to be made. I think what we deal with in the hospital is often crisis management and seeing people frequently that are much closer to the end of their lives. But the aim of this project and of training providers is to have conversations much earlier. And again, that it is iterative and will occur over the course of a disease trajectory, again, because people's goals and priorities change as illness progresses. And you can see the many benefits, providing more time to make informed decision, lessening the burden of decision-making for families, helps loved ones, if they have information, be better prepared as caretakers. It also deepens our relationships as clinicians with our patients and has meaningful connection at times when people need our help the most. And that is why I think many of us have even gone into medicine. So some tips for clinicians, speaking with clinicians rather, for you to speak to clinicians, is ask for a dedicated visit to talk about the future with your illness and your future goals. Prepare in advance for the visit. Ask for the information you need. Ask for clarification when needed. Have a buddy at your visit to take notes and help provide support. And if you have a proxy or a living will, bring a copy to your appointment. And how do we prepare to speak with clinicians about serious illness? Well, the Conversation Project has created a workbook specifically for people living with serious illness. And the questions in the workbook mirror those that we're training clinicians to be asking patients about. So what is your understanding of your current health situation? How much information of what is likely to be ahead with your health would you like from your team? What's most important for you to have a good quality of life? What are your most important goals if your health worsens? What are your biggest fears and worries about the future? There's also a guide for helping you to talk with your healthcare team. So again, this guide can empower you to ask for information that you need. And here's a list of questions. Can you tell me what I can expect from this illness? What is my life likely to look like 6 months from now, 1 year from now, 5 years from now? What are some big possible changes in my health that I should be prepared for? What can I expect to get better if I choose this treatment? What are my other choices? What if I decide to do nothing? What will my quality of life be like? Sometimes expert help may be needed. So you've been speaking with your primary care physician or your specialist, whether it's oncologist or cardiologist or whoever. And if you're getting mixed messages from clinicians, if there's family conflict, if medical recommendations are at odds with your religious, spiritual, or cultural beliefs, clinicians aren't providing you with the information you need or want, or you have inadequate emotional support, that's when you should request for a palliative care consult. So what is palliative care? Palliative care is specialized medical care for people living with serious illness. It focuses on providing patients with relief from the symptoms and stress of the illness. And the goal is to improve quality of life for both the patient and family. For further details, I think, to help explain, is that palliative care is provided by a specially trained team of doctors, nurses, and other specialists. So that includes social workers, nurse practitioners, Spiritual care also can sometimes include pharmacists or other mental health providers. And when we say specialists, for instance, physicians need to go through a fellowship, just like a cardiologist would or a nephrologist, and then have board certification. Likewise, in other disciplines, they also have board certification process. We work with your other doctors to provide an extra layer of support. So you don't need to give up the care of your other providers. We all work together. Palliative care is based on the needs of the patient and not on the prognosis. So we don't recommend waiting until someone is in the final weeks of their lives to involve palliative care. If somebody has needs that are not being met in terms of high symptom burden or communication difficulties, then palliative care can be helpful at any age, at any stage in a serious illness, and can be provided along with curative treatment. Key aspects is that we focus on identifying and managing sources of stress and symptoms. That includes physical symptoms such as pain, nausea, shortness of breath, emotional symptoms such as anxiety and depression, and spiritual distress. We focus on bidirectional communication about illness understanding, medical decisions that need to be faced, and learning, again, what matters most to the patient and family to ensure that the care is aligned with your values and goals. And then we also focus on care, a coordination of care. Sadly, data shows that care is incredibly fragmented for seriously ill patients in their final year of life. On average, these people see over 10 physicians in the final year of their life. People also spend a lot of time in hospitals, averaging over 16 days in their final years of life. So care does become quite fragmented. And treatment is siloed, where the focus tends to be very intensely on cure versus comfort. But the reality is people need a lot of attention to comfort while they're focusing on cure, and palliative care helps bridge that gap. This is a shorter definition by the founder of the Center to Advance Palliative Care. Palliative care is about living as well as you can for as long as you can and helping to lift the burden of living with an illness. So where is palliative care provided? Well, it first started in hospital settings with palliative care consult service. And this is really for episodic care during hospitalizations. We have an entire team available to provide support. We often see people for multiple visits during a hospital stay, and often may see patients over multiple different hospitalizations. A lot of what we do in the hospital is helping with crisis management, and we're really seeing people at their sickest and supporting patients and families. In an effort to support people earlier in illness and before crises develop, palliative care has been expanding into office settings and into the homes as well. And studies show how palliative care has a greater impact the earlier we're involved in patient care. So office-based palliative care is becoming more common and is most commonly seen in places where cancer care is delivered. The way this works is that they're ongoing palliative care office visits in conjunction with the patient's oncology team. And the palliative care specialists assist with symptom management and also help with advanced care planning and serious illness conversations that evolve over time. And often people are being followed for months to years. Home-based palliative care is a newer area. It's being provided by some home care agencies or through even hospice organizations may have a palliative care organization or arm that's separate from hospice. And Mass General Hospital actually has a home-based palliative care program. And these typically are intermittent home visits with a palliative care specialist, either a nurse practitioner or physician, who will assist with symptom management. And they serve as a consultant to the primary care doctor or the specialist who made the referral, but they also can help with ongoing discussions about how the illness is impacting quality of life and what the goals of care are. So the Newton-Wellesley Division of Palliative Care, we can brag about this. We've been in existence for 12 years, over 12 years. The service has grown considerably. Our division chief is Dr. Kosha Thakur, the upper left photo. But we currently have 4 physicians, 3 nurse practitioners, 2 social workers, an administrative assistant, and we work in close collaboration with the spiritual care department. We offer inpatient consultation in the hospital 5 days per week, Monday through Friday, and we have office-based palliative care at the Mass General Hospital Cancer Center at Newton-Wellesley, 5 half days and growing. Future growth of the service is planned to expand to 24/7 coverage with palliative care in the hospital, and to offer 5 full days of office appointments in the cancer center. We also hope to expand to offer office-based palliative care for non-cancer diagnoses. So what can you do now? You can engage in advanced care planning with your loved ones. When faced with a serious illness, ask your doctors and other providers to help you prepare for the future. Ask to meet with palliative care if you or your loved ones or your doctors are struggling with managing the symptoms and stress of a serious illness, preparing for the possibility that your health will worsen, or in making complex medical decisions. And I would like to end with this beautiful photo of a patient I saw for a palliative care consult during her hospitalization at Newton-Wellesley in June of 2021. Her name was Cookie. She had cardiac and pulmonary disease, and her condition was somewhat tenuous, and prognosis was uncertain, but was felt likely to be weeks to months. We had a meeting with Cookie and her family to talk about her condition and prognosis and goals. And Cookie was very clear that her priority was to be out of the hospital, to go to Cape Cod, to see more sunsets, and to maximize her time with family. Given her wishes, we recommended hospice care. She went to the Cape and saw many sunsets, and was fortunate to have 5 more months with her beloved family, creating beautiful memories with them. They were so delighted with how things turned out that they shared the story and sent this photo, and with their permission, let us share that with you today. And I'll end on another amazing quote by Dr. Gawande. The goal is not a good death. The goal is a good life all the way until the very end. Thank you.
Dr. Raglin, thank you so much. There was amazing information, and I think you gave us a lot of ideas about how we could go this path in this journey in the way that we would like to, in terms of that aligns with our own goals, but then also be able to talk to our providers about what those are, and to have them help us in that. So thank you so much. I did want to share that Dr. Raglin is very generous in that we will be sending out her slides after this presentation, as well as a variety of different resources that include books and articles and links to the different websites that Dr. Raglin has referenced in her presentation. So all of that will come post this presentation in the next few days in an email to all of you who have attended. So that will be hopefully helpful for you and your family and friends. So now we are going to go to the question and answer portion of the program. And we did get a lot of great questions in that are top of mind for people. So I will just dive right in so that we can have time to respond to these. The first is that I think is a good question that speaks to, do all service lines enjoy partnership and or trainings with our palliative care experts? So how kind of deep within the variety of services that Newton-Wellesley provides is palliative care engaged?
Yeah, oh, that's a wonderful question. Thank you for asking that. So in the hospital setting, we collaborate very closely with all of the different service lines. So we work closely with our colleagues in critical care in the intensive care unit, with the cardiologist, with the oncologist. The bulk of the majority of the cases that we see in the hospital setting are for people who have cancer and who've been hospitalized. Because we work closely with our cancer oncology colleagues in the cancer center, I think that's also increased the amount of referrals that we get. So we have that close collaboration both on the inpatient and the outpatient setting. We have also worked through our training programs in serious illness to train all of the specialists that are involved in taking care, who commonly are involved in taking care of people with serious illness. And this is not just the physicians, but also advanced practice nurses, physician assistants, the hospitalists who work in the hospital. We've even taught the physical therapists, occupational therapists. We're really trying to spread the word so that anyone who is caring for someone with serious illness has the skills and language to help support these people in a number of different ways.
Great, thank you. And I think this is an excellent question that definitely weighs on people's minds. Could you share some tips if family members are resistant to speaking about advanced care planning, that they would want to avoid talking about it? How do you go about that, navigating?
Yeah, so I think that I would validate that. I would acknowledge that that's really normal. Like, these are hard things to talk about, but I would then talk about how it would help you personally. It would help you to feel better, to know that you were able to express what matters most to you, and that you need their help. I'm thinking of the person who has who's worried about their future and their future health, or may have the serious illness, to bring it up and let them know, you'll really help me if you can let me talk about the things that matter to me, or the things that I'm worried about, because I've learned that it's highly likely that you could be in a position to make decisions for me. And I worry that I may not get the kind of care that I want or that matters to me. So I would say that that is a benefit. Now, let's say you're on the flip side and you are not sure how to bring it up to your older relative or somebody who has a serious illness. And I think, again, you can say, you can use some of the information here. I've learned that a lot of people end up in a crisis they weren't prepared for. And I know that you've chosen me as somebody to make healthcare decisions for you. And it's so important that I really understand what matters most to you. And, would it be okay if we talked about that? And I would also recommend, as I mentioned, all of the websites pretty much that I mentioned really have excellent resources that talk about these exact issues that you're talking about, with maybe more eloquently, because they've thought about it and written it out, but can give you step-by-step language to think about how to bring this up with people that are not ready to do it. So it's a really good question, and it's very common. But I think, again, many people worry about this, but are relieved, as I said, to actually talk about it.
Excellent, thank you. And this is another common question, I think, to make this distinction in terms of what is the difference between palliative care and hospice?
Yes. So this is a very common question, and something that we need to address a lot in the hospital setting. And it's often a barrier for people to get the palliative care help that they need, because people equate hospice with end of life, and with death and dying. And in truth, hospice it's a type of care that is provided people specifically who are at the end of their lives. It is for people who are felt most likely to be in the final 6 months of their life. They need two physicians to certify that, given the natural course of disease, it's likely that their prognosis is less than 6 months. The focus is exclusively on comfort care. So in fact, it's all palliative care. It's all about comfort. So what that means is that the patient has accepted that they no longer wish to pursue life-prolonging or curative care, or they've been told by their providers and they've sort of accept that there really are no more good options for prolonging life, and extending that. And so hospice is team-based care, again, to ensure that you have the best quality of life in those final stages of your life, and is most commonly provided out of a hospital setting with the aim of keeping you out of the hospital setting. The problem is that many people with serious illness, most want to live longer. They want to pursue life-prolonging treatments. They're not ready to give up on gaining more time, but they still suffer from many of the symptoms and burdens of serious illness. they still struggle with making decisions about certain kinds of treatments and how and where they want to spend their time. And so that's why a palliative care specialty exists, is to help people when they have serious illness and before they're ready to do hospice care. I hope that helps.
That's great. Thank you so much. And then another question, these are just excellent questions. Another thing that people I think grapple with is, do you have any suggestions on how to choose a healthcare proxy? And further, does it have to be a spouse? And maybe how do you deal with kind of, choosing someone that might not be the expected person for your healthcare proxy?
Yeah, so that's a good question. I think some people feel a sense of maybe obligation to pick their spouse. That may be the person that they're closest to for many reasons. But as I mentioned, it can be, first of all, very emotional for somebody to serve in the role of being a decision maker. It needs to be someone who can feel comfortable that they're representing your wishes and not necessarily their own. As you can imagine, a spouse will feel very conflicted. They may want to do everything at all costs to not let go of you, whereas that may put you, into care and getting the kind of care that maybe you really didn't want for yourself. You didn't want to be a burden. You didn't want to extend that difficult time. So you really want to choose someone that you think will feel most comfortable being able to represent your wishes, someone who you think can handle that emotional burden of being the decision maker, someone who's likely to be available and able to process information pretty quickly sometimes, because things can evolve in the hospital setting in particular pretty quickly, and physicians often need to reach out with new information and ask the proxies to make decisions. So I think those are things to factor in. There is good language on the websites too, if you choose somebody else, on how to talk to your spouse, maybe about why you didn't choose them. Like maybe you want them just to be your spouse and focus on you and supporting you and not being so mired in all of the nitty details of decision making.
Excellent advice. That's great. I think this is an interesting one, just to think about, because of, you've talked about so much training that's being conducted and your great integration with the palliative care service into other services within the hospital. But I think this kind of lends itself to some thought or some comment. So if all this teaching and training is going on, why isn't it brought up with patients more often?
Yeah, so that $64 million question.
Yeah, right. I know.
And I said that accidentally, but in fact, I hate to say it, but financial reimbursements unfortunately do play a role, but there really are many factors. One is that there's tremendous time pressure. When we ask clinicians, what are the barriers to implementing, having conversations, time is the number one. They feel crunched. They've got these short appointments, and how can I have this kind of conversation? They also have a lot of their own anxiety. These are hard conversations, and it's hard to bring up things that might become sad or difficult. It's hard in the serious illness conversations. We expect the clinicians to talk about prognosis and that things are likely to get worse over time. And it's, we're human beings too. Like, we find that difficult to bear that news. I have to say though, and people find this hard to believe. They don't understand how I could do this all the time. But what we find is, people have this serious illness. They often know the situation is not good and it's not going to get much better. And they're worrying on their own. And they find that when they meet with somebody like myself or a primary care doctor or anyone else who has an open conversation and provides them with the information they want, that this can be hope-giving. And they are grateful for the information, and they're grateful to have the opportunity to talk about what their worries are. And so we hope when we train and encourage providers that they start doing it, even though they're uncomfortable. And when they start seeing the benefits of it, that it will build on itself, and they will recognize that this is an important role and something that they do. So I think time the training, the anxiety, and then, as I mentioned, they are under pressure. They get reimbursed more, and it's not conscious, but there's just such pressure to see more patients and do more procedures. And those things, unfortunately, in this day and age, are given more reimbursement than having conversations, which I think is pretty sad. But
All right, so I think we have time for one more question, so I'll ask that and then we'll wrap it up here. And it's kind of more of a logistical question. You have touched on it a little bit, but how does it really work when you are asked to provide a palliative care consult? So kind of how does that get triggered and how does it all operationalize within the hospital?
yeah. So in the hospital, anyone can think of, maybe a palliative care consult would be helpful. And now that we've been around for a long time, it can literally be a speech therapist might make the recommendation. It may be that the nurse recognizes they're hearing the patient, express a high degree of suffering, and that they're worried they might be dying, those kinds of things. But most often it's the medical team themselves. Whoever has the idea that a palliative care consult may be needed because there are unmet needs, whether that's unmet symptoms, that pain and symptoms are not being addressed, that people are kind of feeling like we're not sure what we're working towards, what are the goals here that we're aiming for with all our medical interventions. They will put a consult in, and the attending physician needs to agree that is appropriate and goes along with care. We encourage the team to let the patient and family know that they've asked for palliative care to come to help address whatever the need is. We see that you're frustrated, that you're getting conflicting messages. We hear that you're worried about what the future holds. We are bringing these experts in to help us with symptom management. And then we start by speaking to the people who referred us. We do a thorough review of the record. We may reach out to other key providers. If it's a cancer case, we'll be speaking to the oncologist to get an understanding of where do they think this person is in their illness? What treatment options are still available that are being considered? We are looking to see if other conversations have happened in the past. And I'm glad to report that more and more we are finding evidence of that in the medical record. And then we go and we meet the patient or the family if they're present. If we don't meet with the family at the first visit, we absolutely look to meet with the family at future visits, because we find that conversations about the illness, the impact on illness, what the future holds, what are the priorities, are most effective if all of the people that care and are involved in decision making are present. And we consider a patient and family meeting to talk about illness, prognosis, goals, and treatment options that align with those. That is like our surgical procedure. This is what we are most expert in. And so our first visit is often about introducing who we are, what we do. We explore how the illness is impacting somebody physically, emotionally, spiritually. So we're thinking of ways that we can be helpful to that person. Maybe I'm making changes in their pain medication. Maybe they're struggling with constipation. But then we also explore where that patient is at in terms of their illness understanding. We ask them what kind of information they want or need. And then we work together with the other providers in the hospital and the rest of our team, the social worker. We collaborate with spiritual care to address the needs that we've identified. And we come up with a plan in terms of what communication is needed, who needs to be in the room. So many times sometimes a meeting will be just with us. They may not need a big decision, but the patient wants to get the family together to kind of talk about the future. But sometimes we may be involved with an oncologist who might be sharing that, unfortunately, the patient is too ill to get more chemotherapy. And so we will help in that conversation with the oncologist and the family members to support the emotions that people are experiencing and to figure out how to move forward with decision making. And whatever happens in our conversations, then we document them, and we also speak to pretty much everyone and their mother in the hospital who might be involved. Care is incredibly fragmented and chaotic. in the hospital, but in particular for people with serious illness through wherever they're getting their care. And so we do our best to act as a bridge to make sure that anyone who's involved in their care is getting the information they need, whether they're inpatient providers or outpatient providers.
Excellent. That was just a great overview of how it really all works. So thank you so much. Dr. Raglin, this was amazing information, and I really want to thank you for spending your time this morning and giving all this content and your insight into this process and sharing tools and resources with us. As I mentioned to everybody who's attended, we will be sending out a follow-up to this webinar, and that will include links to all the different things that we've talked about this morning, as well as articles and book suggestions on this subject. And that will come from the Newton-Wellesley Hospital Collaborative. So you should look for that in your email inboxes in the next day or so. And I do want to remind everybody that the collaborative has actually a continuous menu of programs on a variety of different topics. And all of these can be found on our website at www.nwh.org. And we continuously update this. So we ask that you check it regularly so that you know what is up and coming, and hopefully can register for those, as well as spread the word among your families and neighbors and friends. So on behalf of Newton-Wellesley Hospital, I would like to thank everyone so much for attending this morning. And we hope to have you join in a future webinar as well. Take care and have a wonderful day.
Thank you, everyone.